The hour of 1:30 having arrived, we'll call the House File 5 Conference Committee to order. We have a quorum. The legislative assistant will note the roll. And I have a special announcement. I think that on Chairman Shoemaker's the eve of his birthday, I'm just so thankful that he is sharing it with all of us. So thank you and happy birthday tomorrow, Mr. Chairman. Okay. I'm so thankful my birthday is August 28th because we shouldn't be here. I hope we're not here. Okay, so with that being said, we'll start out and welcome conferees. We're very happy you're here. We have a very important bill to a conference committee here to put a very important bill together regarding reinsurance. So with that, it's my intention to do the side-by-sides from nonpartisan staff or partisan staff. Some staff. Nonpartisan staff? Yeah. Nonpartisan staff. Very, very good. And then I have on my schedule 5 testifiers, Rose Roach, Mr. Jim Showalter, Eleanor Haas, Dave Zaffron, and Twyla Brace. Is there anyone else in the audience that wishes to testify on behalf of this bill when we get to that portion? It would then be my intention to take a recess to the call of the chair, and we will go from there. So with that being said, let's start with the side-by-side. Ms. Pompeau, if you could go to the desk here maybe, or yeah, why don't you go to the desk if you would, please. And Senate, let's work together here, as we always do. So members, you should have side-by-sides in your packets. And so who would like to start? Ms. Pompeau, if you could please state your name and who you represent for the record, please.
My name is Laurie Pompu. I'm with House Research. Chair and members, if you look on your side-by-side, beginning on page R1, the left-hand side is the House language. That's the fourth engrossment of House File 5. We begin by adding a definition stating that contributing member includes an eligible health carrier, which is defined later, and that a plan enrollee means both a plan enrollee under MCHA as prior and an enrollee in the individual market as defined later. These same definitions are picked up in section 2 on page R1, and that's it. Over to the Senate.
Please state your name and who you represent for the record, please.
Mr. Chairman, Chris Stang, Senate Council Commerce Committee. The Senate on page R1 modifies the Board of Directors of MCHA by adding 2 members. Selected by the Commissioner of Human Services, one of whom represents hospitals and one of whom represents healthcare providers. We also get rid of the weighted voting that's currently in law for the MCHA board, and remove the language related to assessing contributing members of the association for board meetings. Mr. Chairman and members, continuing at the bottom of page R2, these are definitions for the new reinsurance program, and continuing on to R3, the definitions are quite similar between the 2 bodies. The House has several additional definitions, including defining individual health plan and payment parameters. And for the attachment point coinsurance rate and reinsurance cap, they reference in their bill where it is, and we provide a explanation of what it is on the Senate side. But in general, the definitions are quite similar in both bills. That would take us down to R4. On the Senate side, Section 3, duties of the Commissioner. The Commissioner is instructed to require health carriers to calculate what their premiums would be in the absence of a reinsurance plan. And the House does not have a comparable provision on that.
No, I got it.
Ms. Pompeau?
Yeah. On to R5. The House language talks about the Minnesota Premium Security Plan. R5 talks about the association's ability to apply for federal funding and that funding has to be deposited in the Premium Security Plan account, that the association can collect data and how they have to deal with that data from eligible health carriers. And it also gives timeframes for when the association has to notify eligible health carriers of the reinsurance payments that they will make, as well as when they must distribute the reinsurance payments. And there is a provision in here, if you look at 6.9, that if the amount in the premium security plan is not adequate to fully fund the approved payment parameters, that they will be readjusted with the board consulting with the Commissioner of Commerce and Management and Budget to create new payment parameters. On to R6, it talks about the payment parameters on the House side, specifically that the attachment point for the plan is $50,000 or more. The coinsurance rate for the plan will be between 50 and 70%, and the reinsurance cap will be at $250,000.
Mr. Chairman,
Stang?
members on the Senate side, for plan year 2018, the Senate bill sets the parameters in law at the attachment point of $45,000, a coinsurance rate of 80%, and a reinsurance cap of $250,000. If you continue down on R6, there is a difference between the bills on in terms of the board proposing payment parameters for other years to the Commissioner of Commerce. The Senate bill gives the Commissioner the power to approve or reject the payment parameters that were adopted by the board, and I believe the House bill does not give them the Commissioner that authority. They have 14 days to approve it, and if they're not approved, they're deemed approved.
Ms. Pompo?
Chair, on line 6.15, the House language starts with the calculation of the reinsurance payments. That is very similar to, if you go on to R7, to the Senate language, that it's the claims cost minus the attachment point, or the reinsurance cap minus the attachment point. That the reinsurance payments cannot exceed the amount paid by the eligible health carrier. If you go down to 6.28, it's eligible carriers' requests for reinsurance payment and the different items that an eligible health carrier has to meet in order to be eligible for reinsurance payments, that they have to apply the payment parameters, that they have to request payments in accordance with requirements established by the board, that they have to calculate the premium amount that they would have charged in a benefit year if the plan was not in effect and submitted as part of their rate filing, that they have to meet the data requirements for the Federal Risk Adjustment Program, and timelines for them to provide that data and access, and that they have to maintain documents and records for at least 6 years. And that finishes up on R8, that they can follow the appeals procedure under section 62E10 sub D2A.
Okay, thank you. Mr. Stang?
Mr. Chairman, I think we're at the bottom of page R8 now, where begins the requirements as to accounting and reporting and audits of the reinsurance plan. The language is quite similar. The House on 8.11 and 8.12 has additional accounting required for funds appropriated for reinsurance payments and administrative and operational expenses. The Senate does not have that in their side. Over to page R9. There's some reporting requirements. The House has an additional report on 8.22 to the standing committees of the legislature having jurisdiction over health and human services and insurance. The Senate does not require. On the Senate side, the Senate gives the legislative audit authority over this program. The House does not have that provision. The external audit required of the board, the language is very similar between both bodies. I'm on page R10 now. I think we're down to the plan account on each side now.
Ms. Pompo?
Chair and members, yep, we're on R10, line 9.19. Both items talk about creating a fund in the special revenue account to put money transferred, appropriated, or held by the Minnesota Premium Security Plan Association, I'm sorry, the Minnesota Comprehensive Health Association, there we go, into the account. Further on the House language, the 1% premium tax on health maintenance organizations, nonprofit health service plan corporations, and community integrated service networks is redirected from the Healthcare Access Fund to the Premium Security Plan account. On R11 of the House language, $70 million is transferred in fiscal year 2018, 2019, and every year after from funds collected on taxes to insurance outside of the amounts already appropriated from HMO taxes. 10.21 is a data practices provision, which relates to the premium subsidy program in Senate File 1. And then the Senate has it.
Mr. Stang?
On the bottom of page R11, on the Senate side, this is a provision the House does not have. The Senate sets up a legislative working group with relevant chairs, the purpose of which is to advise the MCHA board on adoption of the payment parameters for plan year 2019. The language also requires the Commissioner of Commerce to provide technical assistance to this working group. On R12 now, we're to the innovation waiver language. Both House and Senate have language on this. The Senate has more detail than the House in terms of what the waiver application has to include. And that language is lines 9.9 to 9.21 on the Senate side, including keeping funding for the basic, for Minnesota Cares, the state basic health plan, held harmless, and also that the state directly get the funding for tax credits that would have otherwise been due to consumers in the individual market if this plan did not exist. We're on R13 now, I believe. Oh, thank you. The Senate has an appropriation to the Department of Commerce to prepare this waiver in the amount of $155,000, and the House has no appropriation for this.
On R13, line 11.
Pompo?
Oh, pardon me, Chair and members. On R13, line 11.27, the House language states that costs related to implementation of this act are to be borne by existing appropriations of agencies. And then on to R14. The House language provides that notwithstanding any other law to the contrary, the Board of Directors of MCHA shall set the payment parameters for benefit year 2018. On to Section 15 of the House language provides that within 10 days of the effective date of the act, MCHA has to deposit all money it holds into the Premium Security Plan account. And a tiered funding mechanism is created where federal funds are used first, and then funds deposited under Section 15, which is the MCHA, the money held by MCHA, and then $50 million of the transfer in Section 18, which is the HCAF transfer, and then funds deposited pursuant to Sections 9 and 10.
Mr. Stang?
Mr. Chairman, on the Senate side, also have an order of funding for the program. Federal funds first, then funds of the association, state funds from the Healthcare Access Fund, and then lastly, state funds from the general fund. And in lines 8.4 to 8.12, if any of these funding sources are not used, the MCHA board must return it to the Commissioner of Commerce for redirection into the fund from which it came. Another difference is the Senate puts a cap on payments of claims from the reinsurance plan on lines 8.13 and 8.14 at the amount of $300 million a year. The House has no such cap.
Ms. Pompo?
Chair and members, on to R15. This first section provides for the funding of the Minnesota Premium Security Plan during fiscal years 2019 and thereafter. Paragraph A provides that operational administrative costs would be paid for by an assessment on those members of MCHA. Paragraph B provides a tiered funding mechanism very similar to that which was created for 2018. On to 13.4, it's a transfer of $80 million in the 2018-2019 biennium from the Healthcare Access Fund to the Premium Security Plan account.
Mr. Stang?
On the Senate side, the funding is as follows: $180 million in each year from the Healthcare Access Fund, and then a $120 million in each year transfer from the budget reserve to the general fund into the reinsurance account. And I think that wraps up the Senate side.
Ms. Pompo?
Chair and members, on the House side, we have a repealer of a 2013 session law that provided for the wind down and termination of the MCHA health insurance program. And then we have an effective date. I would note that the one section with a different effective date is the HMO premium deposit section.
Okay. So members, at this point, we'll go to questions from members to Ms. Pompo and Mr. Stang regarding the side-by-side. Okay. Thank you very much for your presentation. We will now go to testimony. And also, we have visited a little bit here with the Department of Commerce. Commissioner Rothman, we're very fortunate to have him here with us today, and Mr. Peter Brickwitty. Is he an assistant or deputy? Assistant. Why isn't he a deputy? Okay, keep working on it. Okay, I'll let you call that one, Commissioner Rothman. That's up to you. Okay, so with that, we will start taking testimony, and I've got 5 people on the list, and please make sure that we testify to the bill, not to something that's not in the bill. So I'll be watching that very closely. Ms. Rose Roach, Executive Director, Minnesota Nurses Association, we're very happy that you're here today. If you could please present your testimony regarding House File 5 and the Senate File 720 that we have before us.
Thank you. Good afternoon, Mr. Chair, committee members. My name is Rose Roach, and I'm the Executive Director of the Minnesota Nurses Association.
Welcome to the committee.
Thank you. It's good to be here. The Minnesota Nurses Association asks you to oppose the taxpayer-funded reinsurance. It is not the solution to the crisis in the individual market. The governor has a better plan that would provide Minnesotans in every county of the state access to care with more affordable premiums.
Ms. Roach, could you talk about the bill before us?
Okay.
Not about a plan that's not in here.
Got it.
Thank you.
The crisis of skyrocketing premiums in the individual market has one group to blame, and that's the insurance companies themselves. To cut costs and maintain profits, insurance companies jack up premiums and deductibles and kick providers out of their networks. Those solutions increase barriers to care. They do not decrease them, and for nurses, that is simply unacceptable. Taxpayer-funded reinsurance simply doubles down on the already failed system of private insurance. And what do we get in return for our money? The insurance companies admitted during testimony, and even during a statement this week, that they don't know if our hundreds of millions of dollars will lead to lower premiums. They said premiums could still go up. And the author of one reinsurance bill, Representative Glenn Grunhagen, said during testimony that reinsurance alone will not decrease premiums. But what we do know is that insurance companies will continue to spend precious public dollars towards excessive administrative expenses, high salaries, and other wasteful spending. There are zero guarantees that reinsurance will do anything to bring premiums and costs down, or that access through expanded networks, particularly in greater Minnesota, will be increased. No, we can't afford any more public tax dollars being dumped into the insurance companies' bank accounts with no accountability and transparency in knowing exactly how much of those tax dollars are actually being spent on care. It's time to stop making the taxpayers of Minnesota shoulder the debt of insurance companies and then letting those same companies turn around and keep the profit, or maybe I should say reserves. Health is not a consumable good, and after more than half a century trying to get people health care through a private insurance market-based system, it's clear it can't be done. When are we going to stop trying to make the market work for insurers at the cost of patients? Please, your nurses beg you, put the value of people's lives and health above the bottom line of the corporate insurance system. Sending taxpayer money into the black hole of the corporate insurance industry with no plan to ensure that Minnesotans get quality health care for this money is not the solution. In fact, it is bad public policy. On behalf of our patients, the Minnesota nurses strongly urge you to reject taxpayer-funded reinsurance. Thank you.
Thank you, Ms. Roach. Questions from members for Ms. Roach? Senator Kiffmeyer.
Thank you, Mr. Chair. Just a quick question. Could you tell me that if we don't do this reinsurance program, would there be a guarantee that the insurance rates would go down without this?
Ms. Roach.
Mr. Chair, Senator? I'm sorry, Kiffmeyer? So the question is, if you don't do reinsurance, is there a guarantee that the rates would go down?
Correct.
There is never a guarantee that rates will go down, which is the problem with the
Thank you,
system.
Mr. Chair.
Senator Kiffmeyer. Thank you. Questions for Ms. Roach? Thank you, Ms. Roach. I'll put you down as a maybe for my bill. I'll put you down. Mr. Jim Showalter.
I know.
Please state your name and who you represent for the record, please, sir.
Certainly. Thank you, Mr. Chair. Members, for the record, my name is Jim Showalter. I represent the local nonprofit health insurers of the Minnesota Council of Health Plans.
Welcome to the committee.
Thank you very much, Mr. Chair. We share the frustration and concern that you just heard expressed and that you and other Minnesotans have about how we pay for medical care. We appreciate the significance of the reinsurance proposals found in House File 5 and Senate File 720 and support their approach. I believe that passing something soon is critically important to the people who will buy insurance on their own in 2018 and beyond. As local health insurers, it's our fundamental duty to make sure that our members' medical bills get paid and that the people get care as they need. It is a responsibility of Minnesotans who work in these organizations, and it's a responsibility they take very seriously. All public money from a reinsurance program will help pay the high medical bills of some Minnesotans, and that in turn lowers the premiums for everyone who buys insurance on their own. There's a direct link between broad financial help and how expensive premiums will be next year. I acknowledge that reinsurance is a complicated and awkward way to address a chronic problem, that medical care we receive is more expensive than we can afford. But there's no way to dodge our medical bills. If we just move those bills around, we should at least try to make it clear and practical. I know some of you believe insurers have financial resources to simply solve the crisis. It is true that in 2014 and 2015, local plans paid more than $500 million in medical bills that individual premiums didn't cover. And when 2016 numbers are result at the end of this month, you're going to see that the trend continues. But using one-time funds for long-term commitments threatens the ability to continue paying those medical bills for all 4.8 million people that they serve. By now, I'm sure some of you are thinking, Showalter has not provided any guarantees, and that's also correct. If problems in healthcare were small enough for any one of us to solve on our own, we'd all be relieved and we'd be moving ahead. But no insurer in the country could make such a promise so early in the year. There are simply too many unknowns. These include the rules for doing business. State and federal guidance that direct what's expected for insurance filings are not complete. Current enrollment. We're just wrapping up the open enrollment for 2017 and have little information on basics like how many people might buy insurance or how sick are they. Insurance is a data-driven project, and at this point, there's little or no data for insurers or regulators to project into next year. Statutory changes in Washington, D.C. and St. Paul more than any other year. I don't need to underscore, but these changes can have a profound impact on the cost of medical care and the premiums that people pay. Both House and Senate bills have many similar provisions and offer practical help for paying high medical bills that lowers what insurers must charge for premiums each month. As you work out the differences, I also recommend that you consider technical fixes to the earlier help that you offer to individuals that found in Senate File 1. But in conclusion, we're all working through great uncertainties, and we're trying to make sure that individuals and families do not suffer. We have local, mission-driven insurers that have continued serving Minnesotans even though larger, better-funded insurance companies fled other states. As you've already heard directly from the leaders of our local insurers, they're committed to continuing serving all Minnesotans, whether they get insurance through their employer, government-supported program, or whether they buy it on their own. Thank you for the chance to testify, Mr. Chair.
Thank you, Mr. Showalter. Any questions from members for Mr. Showalter? Senator Abler?
Well, thank you, Mr. Chair, and I appreciate you coming down, and I know a lot already, and so I'm on this committee because I care about the process and the need and the challenges, and I wish we weren't here. I actually long for the days of past, and we talked about that on the floor. Looking back wasn't wonderful, but it's better than this. But here we are, and so the governor has talked about you. Could you be assuring us that you're going to participate if we do this? And I'm sure you have a couple of thoughts you've prepared about that. I'll be asking more about that later and pressing you for a better answer. But if you want to give your comment about that, that'll be good for now. Thank you.
Mr. Showalter, you please give us a better answer.
Mr. Chair, Senator, I will try. But the simple fact of the matter is there's no guarantees in life. Certainly in this instance, we're looking at 2018, and there's set pieces of information that insurers couldn't tell you what's going to happen in a normal year, and this is certainly not a normal year. Those things include, as I said before, guidance about what the rules of insurance and what kind of provisions are going to be expected from insurance filings. Those include data, understanding the people who are buying insurance and who's expected to show up. That directly drives the medical bills that premiums are supposed to support. And finally, whether we've got statutory guidance from the state or federal government that's going to be changing, again, that could directly impact the medical bills that are expected to be paid by the premiums. Projection or premiums for 2018 aren't a theoretical exercise. Experts at the health plans, at the state departments, and the regulators look at a lot of information, and that information isn't known yet, and that's what's going to drive those decisions. What you can do today is set the stage to stabilize the market, because we're going in a spiral that's going the wrong way. Ultimately, what we need to do is, and I think what you're trying to get at, is get more people to buy insurance and help make sure that high medical bills don't tank the entire market.
Senator Abler?
Well, I appreciate your answer, and I'll just give you a hint about the answer I want for later. In my view, for some of my people, their premiums doubled last year, and 50 to 67% is not accurate to describe what happened to some individuals. Networks are horrible now. They're very limited in my way, a very bad way. And so it seems to me with that kind of increase, there should be some way to stabilize rates about right where they are now, and this would buy them down. So if you can keep that in the back of your mind, and that's what that's what a lot of people are expecting. And I just want to caution the industry you represent. A lot of us have been eager to support it and help it exist and to be here. I think if you don't encourage your members of the board to remember their mission and keep that need to cover costs and all the uncertainties suppressed, there won't be some of you around. And that would be really bad for Minnesota, and I'm not sure I like the other outcomes. So just is that encouraging? But that's where we're at. This is really serious. We're spending potentially $900 million this year to stabilize the industry you represent, and people really want some value for that, not just a reduction of what would have otherwise been. So thank you.
Mr. Showalter.
Mr. Chair, Senator, you don't have to tell me that this is serious, and you don't have to tell your local insurers that this is serious. They know that. They've been living it. But really, at the end of the day, it's not about the insurance companies. It's about Minnesotans. I think that's what we all share. And if we can't find some solutions that work for people, we're going to keep trying, because that's what we're here to do.
Senator Abler. Senator Benson.
Thank you, Mr. Showalter. And you talked about all the changes in guidance at the federal and state level. And in addition to that, as we're trying to move reinsurance through, we're dealing with CMS that's in the process of change. They have indicated that in order to receive some portion of the federal funds, at the very least, that we're going to need a contingency waiver. And I know that I had talked with some of the people in your industry about that. Could you help this committee understand how the industry views that contingency? I have a feeling actuaries don't like contingencies very much, but I would like you to speak to it.
Mr. Showalter.
Mr. Chair, Senator, there's a couple of related thoughts. The first thing is, I don't think anybody likes contingencies on their face, but I think the key thing here is you're trying to take a practical step that's quick and effective to stabilizing how people buy insurance on their own. Some of you have actually talked directly to CMS and what they're looking to do. We certainly have talked with the Department of Commerce about what they perceive as being necessary to get the federal funds that are necessary. And while I think our industry isn't looking for contingencies, doesn't want contingencies, I think the key thing is being practical and assessing what is absolutely necessary to make sure that this program works. The impact on rates is the second and most important thing, is if it's determined that it absolutely has to be contingent. And that's just a matter of course, because that's what is necessary to shoehorn a 1332 waiver request in and make sure that it fits so that we can get it off the ground. If that's what's determined, then the next step is always, of course, then the regulators and the health plans are going to have to work through the filings about how to reflect what we know and what we don't know and when we know it. I don't want to presage all of those conversations, but we're all here in problem-solving mode, and that's where we should be.
Senator Benson.
Mr. Showalter, if we end up with contingency language and the feds come through with them, so if we put contingency language in and you start working on rates and then the feds come through and say, yep, you got the waiver, are you allowed to refile rates based on changes to your environment? I need to know what steps are involved and what that timing might be.
Mr. Showalter.
Mr. Chair, Senator, a great question. Since you and I are both aware of this possibility, I am sure that the regulators, the Department of Commerce and the health plans also are very much aware of how they're going to work through the filings, and whether that means that there has to be two different filings under different scenarios, or whether there's an amendment that comes through. Those are very practical, I think, options that we're going to have to work out, because at the end of the day, the scenario that is alleged from time to time, that this is money going to the insurers, that's not what anybody's looking for. This is money that should be going to individuals and driving down premiums. I am very confident the regulators will make sure that happens.
Senator Benson. Questions from members? Senator Laurie.
Thank you, Mr. Chair. And I'd just like to take note of a couple of things that I heard you say during your testimony. The first was I believe in regards to the potential of using reserves, your own reserves to cover some of these losses. And I just found it a little ironic that you said something along the lines, I don't do shorthand, so I couldn't get the whole thing, but using one-time money essentially for long-term needs doesn't solve any problems. The irony, of course, is this is one-time money. That's just a time-limited, 2-year program, and we're not actually solving anything. So I guess I would like to kind of point that out. And then you wrapped up with that our local carriers are committed to providing insurance for all of Minnesotans. But then, which sounded like it was approaching a guarantee, but then when questioned, there is no guarantee that there would be insurance offerings in the individual market across all corners of the state of Minnesota. So like to learn more about the commitment to providing insurance for all Minnesotans as we move forward.
Mr. Showalter?
Mr. Chair, Senator, I heard two distinct points, and I'm going to try to address them in order. Using one-time money for ongoing operations, absolutely, we both know that doesn't work. One-time money to stabilize, one-time money to offer transition, yeah, that's what it does. That's what the health plans have been doing for a couple of years, trying to stabilize offerings, stabilize premiums so that we would sort out whether more people were going to come and start to buy insurance on their own, whether there was going to be federal help and some of those promises were going to be delivered as originally promised, if ultimately the ACA was how that was going to shake out in Minnesota. The state is now looking at using one-time money or looking at initial ways to just make sure that those options remain available in 2018. I know that we're going to be back here, and you know we're going to be back here next year looking at other options, looking at what's happening in Washington today or next week, trying to figure out what are the next steps to making sure that people continue to get care. And ultimately, we're going to be going to medical expenses, and we're trying to figure out how to not shift costs around, but ultimately make it affordable without all of the transfers back and forth. So on the one-time money, I think actually we're closer than you might than it might have sounded. As far as guarantees, I want guarantees, you want guarantees, we all want guarantees. This is a big problem. It's not the kind of situation where a single act is going to solve it. We're going to need cooperation, we're going to need to work together, and that's what your local insurers have been doing, they're committed to continue doing, and their very reason for being is to serve Minnesotans. That's the commitment that they've been following, that's the commitment they're going to continue to follow in working with you to make sure that people get the care they can. That is the work that they've been doing, and I think this bill makes it more likely that high medical bills won't drive up everyone's premiums. It's not about the insurance companies, it's about how much people are going to be able to pay and how many people are going to get insurance.
Senator Laurie? Other questions from members for Mr. Showalter? If not, we'll go to our, thank you, Mr. Showalter. We'll go to Eleanor Haas. Please state your name and who you represent for the record, please.
Yes, Mr. Chair, members of the committee, my name is Eleanor Haas. I live in Northfield, Minnesota, and my husband and I buy health insurance on the individual market. I spent my career working at the University of Minnesota, and I retired a few years ago. And my husband is self-employed, doing contract work in computers. And for the two of us, our insurance plan from Health Partners costs about $1,500 per month. We are getting a federal subsidy through MNsure to bring our monthly premium cost to about $300 a month. but our deductible is still $3,000 for each of us, $6,000 for the family. And our income is also close to the limit to receive a subsidy. Depending on the work my husband is able to take on, we may go over that limit and lose the subsidy, and then we're left to pay the full price. And I've heard a little about the reinsurance idea, and I can't see how it will make our situation any better. It sounds like a lot of public money handed to insurance companies, but from my perspective, it would still leave everything just as much up in the air about what they'll choose to do, how much insurance will cost, what they'll choose to cover, and what doctors are included. Maybe hundreds of millions of dollars in reinsurance is the price it takes to get insurance companies to continue selling plans. But does this really help people like me? Every year things change so dramatically. The last 2 years we had Blue Cross Blue Shield, but this year they didn't offer anything remotely reasonable in price. And who knows what next year is going to bring. This reinsurance plan doesn't give us any confidence or certainty that it's going to be any better. If we have the same bad plan options, maybe without a subsidy next year and with high deductibles, does all this money really accomplish anything? So far, the clinic we go to in Northfield has been covered, but what about next year? I had heard an option proposed for people to buy into Minnesota Care.
Ma'am, we're talking about House File 5, so let's confine our remarks to House File 5, please.
Okay. I just wanted to say, my daughter works at our local food co-op. She's on medical assistance because her income is so low. With all the turmoil about health care, both at the national and state levels, we don't know what to expect. Families need good options and some sense of certainty that we'll be able to get the health care that we need when we need it. I can't see the wisdom of giving insurance companies $400 or $600 million and hoping that it helps. I'm telling you that we need health care that works and that you have a responsibility to deliver that. Okay, that's it.
Thank you very much. Any questions for Ms. Haas from members?
No question.
Chairman Dean?
Thank you, Mr. Chair. Ms. Haas? Haas, I'm sorry. You said that your premiums currently are at $1,500 per month, and I think you said Minnesota Care, but I think you meant to say...
Oh, it's Health Partners, yeah, I'm sorry. I say that, yeah.
And
Chairman Dean?
you said that you receive a subsidy of that left $300 a month. Does that mean that your subsidy is currently $1,200 a month or $300 a month?
The subsidy is currently $1,200 a month, yeah.
Okay.
Chair Dean?
Mr. Chair, so currently, 1,200 out of 1,500 is paid through a subsidy, and are you concerned that this would increase your current monthly rate of 300, or what is your opposition?
Yeah, I think,
Ms. Haas?
I think that we'll probably lose the subsidy because our income will be too high. And even for us, that $1,500 a month will be a tough amount to come up with.
Chair Dean?
Thank you, Mr. Chair.
Questions for Ms. Haas? Thank you very much, Ms. Haas. We appreciate your testimony today. Thank you. David Zaffron, Take Action Minnesota. Did I say your last name right, sir?
Yes.
Okay. Please state your name and who you represent for the record, please, sir.
My name is David Zaffron, and I'm here with Take Action Minnesota.
Welcome to the committee, sir.
Chair Davids, members of the committee, thank you for the opportunity to testify today. Take Action Minnesota is a grassroots organization that advocates for racial, gender, and economic justice at the local, state, and federal level. I'm here today to raise our concerns about House File 5. Take Action Minnesota opposes the creation of a state-funded reinsurance program. The insurance carriers in Minnesota have gambled when establishing rates in the individual insurance market, underbidding in order to gain market share, and Minnesotans have paid the price. They've had to switch carriers and plans, often losing access to trusted doctors and other practitioners, and they're paying more in the process. In 2014, Preferred One gambled and came out with the lowest rates for MNsure plans. They were the largest carrier and attracted 70,000 new members. However, they lost money on that gamble, so in September of that year, they announced they were leaving MNsure and made other changes to their individual market plans, including narrowing networks. 70,000 Minnesotans were forced to change plans and possibly their medical providers as well. 2 years later, just last year, Blue Cross Blue Shield announced it was pulling its insurance plan out of the individual market, but that Blue Plus, their HMO plan, would remain with narrower networks. Over 100,000 Minnesotans on the individual market were forced to change medical providers, buy a new plan, or change carriers. And this doesn't begin to describe the human cost. This doesn't describe the fear that Minnesotans live with. Will they be able to see their doctor, their mental health provider, nurse practitioner, or other specialist with whom they have a trusted relationship? Will they be able to get the drugs they've been using, or will the new carrier dictate a different drug? Will they be able to pay the premiums and deductibles and copays if they get sick? Will they be chased by debt collectors? Passing this reinsurance legislation will reward those gambles by handing the insurance companies hundreds of millions of taxpayer dollars with no strings attached. There's nothing in this bill that gives us any assurance that will solve the actual problems facing Minnesotans. Access to affordable health care through doctors and providers that they choose. We've repeatedly heard that premiums may still go up, even with this reinsurance program. So we must ask ourselves, if that's the case, what problem are we really solving? The insurance industry has gambled, and we should not reward them with such an expensive gamble of our own. We also oppose the proposed funding for this reinsurance program. Minnesota stands to lose $2 billion per year in federal funding for health care under the American Health Care Act. This bill takes funds out of the Health Care Access Fund, monies that we may need in order to continue providing health care access through our public programs. If reinsurance is the desired approach of Minnesota's health insurance companies, then they should be willing to fund this program out of their reserves or through an insurance surcharge similar to what funded the Minnesota Comprehensive Health Association in the past. Thank you.
Thank you very much for your testimony. Mr. Zaffron, any questions for the witness from members of Mr. Zaffron? Thank you very much, sir. Appreciate your testimony. The next person is Twyla Brace, and then I have Mike Hickey from the NFIB. So, Ms. Brace, President, Citizens Council for Health Reform. Please state your name, who you represent for the record, please, and provide your testimony.
Thank you, Mr. Chair. My name is Twyla Brace. I am president and co-founder of Citizens Council for Health Freedom.
Welcome to the committee.
Thank you. And we have not hidden the fact over the legislative session so far that we do not like the reinsurance program. In particular, we're concerned about the fact that the health plans have this kind of power to tell the legislature what to do. It's sort of like do it or we will not be here. And we know that this power has come from laws that have been passed in this state as well as at the federal level to really empower the health insurance plans. Now, when we look at the Minnesota Premium Security Plan, we came up with a diagram, which some of you have seen in other committees, but what this really shows is that the health plans pay the first, and this is on the basis of the Senate version. The health plans pay the first $45,000, and then taxpayers pay 80% of the next $205,000, and then at $250,000, the health plans pick it up again. But oftentimes they will have their own reinsurance, which is called insurance for insurers. So really what they're going to be responsible for is for the first $45,000 and a little bit of the rest. And so when we had MCHA as the high-risk pool, people knew that they were going into MCHA. They paid more. There were some limits on that. There were only 38,000 people. But in this plan, it puts the entire individual market up to almost 300,000 people into the individual market and into what we consider a new government program. So this is really not people buying insurance. They are buying into a new government program called the Minnesota Premium Security Plan. In addition, our concern is that they will not know that they are in this plan. There's no plan to tell them about this, and that their data, as soon as they hit more than $45,000, their data will be shared with the state of Minnesota for the state of Minnesota to pay those claims back to the health insurance companies. Now, we have spoken with Chair Davids, asking for and providing an amendment to at least let people know if this is going to move forward, to at least let people know that their data will be shared for payment of claims by the state. And we have that amendment with us if you would care to look at it, or we can share it later. The other thing that we would like to say regarding just what has been testified to today. The idea that Senator Lori said, you know, one-time money for long-term costs, and the testifier here said, you know, for a transition. I don't think the question has been answered to what is the transition? Where is this program going? What says that there won't be needed another $300 million every year to continue this program, which is really a facade? It's a new government program with the health plans providing the facade. And again, we also do not believe that there's a guarantee that the prices will go down, or the networks will widen, or the choices will increase. And having just come back from Washington, D.C., I know that everything is completely chaotic at that level, and we have no idea what is going to happen with the AHCA or the Affordable Care Act. I will say regarding the bill, I heard two things. One, I heard somebody say this is for 2 years. Now, I had not known that a sunset was yet put on. If that is a sunset, we would appreciate that the sunset would indeed happen, so at least there was the opportunity for reconsideration in 2 years rather than making this a permanent program. I also want to say that we appreciate the Senate cap of $300 million as a way to make sure that the taxpayers aren't on the hook for more than that. And I'll leave it at that. Just we're concerned about where this is going, and we're concerned about the health plans telling the legislature our way or the highway. Thank you.
Thank you, Ms. Brace. Questions from members for Ms. Brace? Senator Benson?
Thank you, Ms. Brace. You talked about MSHA, and a lot of people pine for those days. You talked about the importance of people paying based on cost. Are we allowed to charge people differently based on their health state?
Ms. Brace?
Mr. Chair and Senator Benson, the interesting thing, I believe that you are perhaps referring to the Affordable Care Act, right? And you are making this a 2-year program, and changes could happen at any time. Anytime. The AHCA, for instance, is going to allow high-risk pools, right? And so there's also going to be the ability, perhaps, before we know it, for people actually being able to be charged differently. But above and beyond that, there's just the fact that the ACA is actually not constitutional, telling you as a state what you can and cannot do. And there has been lots of conversation about state legislators deciding to push against that and actually make their own rules for the state.
So the
Senator Benson?
answer to my question is we can't charge people more right now.
Mr. Chair and Senator
Brace.
Benson, you are only limited by what you are willing to do or not do as a state.
I have a feeling we're going to have a
Senator
hard time, Mr. Chair, getting federal dollars if we start violating existing law. So we're kind of stuck in a box. Things are changing rapidly in Washington, but we have a problem to solve before the end of March for our premium year.
Questions of Ms. Brace from members? Thank you, Ms. Brace, for your testimony. Thank you. Mr. Mike Hickey? And Mr. Hickey is the last person I have on my list here, so please state your name, who represent for the record, please, sir.
Mike Hickey with the National Federation of Independent Business. And,
Welcome to the committee.
Well, thank you. And first of all, I want to say thanks to all of you who have tried to solve this problem. And obviously, we're in a real mess here. We handled this problem probably better than any state, or as well as any state. And Obamacare came along, and now we're dealing with this. And so appreciate what you're trying to do to help our members who are stuck in this individual market and have received horrendous increases. A lot of people have received 100% increases over the last 2 years, and I know there's stories that Senator Abler mentioned that are far higher than that. So we do appreciate what we're trying to do, the buy down of the premiums on your first bill, and now trying to do this. We do appreciate your effort to stay away from bringing back what we thought was a very unfair, inequitable MCHA assessment, and so the fact that you're looking for other financing is really appreciated. Going back to a tax that unfair is not a good solution, and I think that market is shrunk a lot, and I think the levy on that would be a lot higher than the 2% range we had in the days that we had MCHA. Hopefully some federal relief is coming, although today it's not looking very good based on what I keep hearing top of the hour. I quit listening, and so maybe nothing anytime soon, but I think eventually the federal government probably will provide us some assistance. We're hoping for $200 million per year. That would help a lot, obviously. But as you work your way through this, I just wanted to urge you to keep an open mind to possibly some other ideas. We've really, embraced the reinsurance idea at this point, and it looks like this is what we're doing this year. But possibly a virtual MCHA, possibly going back to the MCHA we had before. There might be other solutions in the long-term future that might be cheaper and could work better and might be more predictable. But anyways, I just wanted to say thanks so much for what you're trying to do and the people you're trying to help, because we have a lot of members stuck in this market, and I know you're hearing from them, and this is not pleasant for them or for you. So appreciate what you're trying to do.
Thank you, Mr. Hickey. Questions from members for Mr. Hickey? Senator Laurie?
Just one quick question. I wasn't exactly clear on what you were characterizing as relief from DC, and that you didn't think it was going to come today. Is that because you think this is going to pass or not pass? That's rhetorical. You don't have to answer that. We might. I don't think that the bill that's up on the House floor today is going to provide relief for the state of Minnesota. I mean, it has billions of dollars of lost federal revenue to the state of Minnesota if that were to pass. Just to say, that's not going to be relief.
Mr. Chairman.
Be relief for the federal government.
Yes.
And Mr. Hickey?
Chairman, I was referring to the very specified amount of money to help states with the high-risk pool problem. That's what I was referring to. I know there's other cuts in the bill.
Senator Laurie?
Yeah, so like a little bit of this and a lot of cuts. I mean, billions of dollars of lost revenue from the over 50-year-old partnership known as Medicaid, medical assistance. Not a good trade.
Questions for members of Mr. Hickey? Okay, thank you, Mr. Hickey, for your testimony. Really appreciate it, and thank you for everyone that testified. It's my intention now to go into recess.
Mr. Chair.
To the call of the chair, Senator Abler.
Well, could Commerce come and chat first before we break?
We have offered that, but there'll be a resource.
I have a question.
Do you have a question of Commerce?
Yeah, I'd like to ask a question. I think it would be productive.
Certainly. Mr. Rothman, Commissioner Rothman. Please state your name and who you represent for the record, please.
Mike Rothman, Commissioner of Commerce.
Okay, Senator Abler.
Well, and thank you, Mr. Chair. I'm kind of a value-based, coming from the House, I'm very interested in value as a senator and frugality, and so we bring these staff all this way. We might as well get some money worth out of them and get some comments. But anyway, Mr. Rothman, thank you. There's been a little talk about contingency needs, and on the floor of the Senate, we declined Senator Laurie's amendment about contingencies because we didn't want to do it. But since then, I've been persuaded that we don't have a lot of choice, and so can you help me understand the math? And if you don't know it now, we can get it later. But there's 3 pots of money that I'm worried about, at least that may be affected if we. Let's say we have plan A as we don't do a contingency, we do like next year with just state cash, and plan B is we do a contingency and get the money or not. And so if we didn't do a contingency on plan A, what would happen to the extra, there's whatever proposal we do, say $300 million, how much of that would we, if we get the contingency, we're going to get some of that back. So that's my first part. The second part is what happens to the basic health plan in terms of the math on that if we do the all-cash year 1 plan. And then the third area is the ANTC. And you can, the tax credits, APT, sorry. wrong term, APTC, effect on the MNsure subsidies. So, does you understand? Thank you.
Commissioner Rothman?
Mr. Chair and Senator, it's a complex question and a complex answer. So the rough parameters, as you described them, are correct, that the reinsurance program is targeting around $300 million. It's different in each bill. 297 in the Senate, it's less in the House bill. And basically, we'd have to figure out how much premium buy down we really want to do. Generally, we've been talking about a $300 million figure. The answer depends, because in the Senate versus the House, there are different funding sources being tapped, what would be impacted. So if we utilize funds that go towards the Minnesota Care, it could impact that. The department's position, the governor's position, has been to hold the basic health plan, so Minnesota Care, harmless, and as well the APTC. So the way to do, and in part to do that, is to, first of all, we need to make it contingent, and second of all, we need to be clear about where the funding should come from. And the governor was clear, his position, our view is that it should be a tax or an assessment on premium on the industry, and that way you avoid the problem that you're describing in your question.
Mr. Chair.
Senator Abler?
I think I'll break it in 3 parts, if you can bear with me. So let's just assume a number of 300 just because it's an easy round number. And so if we do this bill, we get all done, send it off, and do everything right with a contingency, we might get some money back from the feds, we think. And so how much of that 300 might come back to us in terms of cash?
Commissioner Rothman?
It's about, Mr. Chair and Senator, about roughly $100 million.
All right, thank you.
Senator Abler?
And so let's say we don't do that method and we spend $300 million of state money from any source, from any good or bad source. And what would the effect on the basic health plan be if we just did a cash only with no waiver thing?
Commissioner Rothman?
Well, without the 1332 waiver, and I guess it's over the next 24 months, there would be a reduction in the basic health plan funding. We could come up with the numbers, but
Maybe
it
we
would
can
be.
phone a friend here.
Senator Abler?
Yeah.
To this point, Senator Laurie?
Yeah, it's in the ballpark of 300 million loss of BHP funding for the 600 million investment in the 2 calendar years worth of reinsurance. So, I mean, it's about 50 cents on the dollar that you put in goes out the back door to the feds if we don't get a waiver.
Mr.
Senator
Chair.
Abler?
Mr. Chair and Senators,
Rothman?
just to clarify, our numbers are somewhere between 287 and 315, so that would jive with what you're saying.
So,
Senator Abler?
And so if we just did cash, we risk losing $150 million on the basic health plan. And then finally, there's these APTCs, not tax capacity. Sorry, the chair was up there thinking taxes, and now I'm thinking tax credits. And so in terms of the loss of APTC, do you have any idea if we just did pay the $300 million, get our reinsurance squared away, we save 20%, the health plans break their arms and really lower it a lot, and they are flat, we're like really happy. How much might we lose on the tax credits? Do you have any idea about that?
Yeah. Mr. Chair, Senator, it's about $100 million, roughly.
Senator Abler?
All right. Well, thank you. So I was just doing some math here, and then I love math. And so if we just do it on our own and we spend $300 million, it seems like we could lose $350 million. And so, no, 100 million on the, we won't get the rebate.
But that's not lost.
Well, but we have to pay the 300. I mean,
Senator
compared to a
Abler?
contingency plan, if we did a contingency, well, anyway, it's
Your point's well
250,
taken.
350, at some point it turns into real money, but thank you, that's all I wanted to know.
Okay. And the other side of that, Senator Abler, is if we don't fund it the first year and the department is not successful in waivers, we don't have a market for 2018. That's the other side. Commissioner Rothman?
Mr. Chair, that's correct. I mean, fundamentally, what we're trying to do is avoid the situation we had last summer, and where there were withdrawals from the marketplace. And just on that point, and what's been said earlier, I just want to be clear that CMS has put it in writing that the contingency must be written into the law as it's enacted.
Thank you, Commissioner Rothman. Thank you for answering those questions on the fly here. I know you didn't have time to prepare for them, but great job, so thank you.
Thank you.
With that, members, it's my intention to go into recess to the call of the chair. We would not be called back anytime before 3:30. So we will need Ms. Windsor and others to contact emails and so forth, so you'll know what time we're going. We'll try to keep you up to date. Senator Laurie.
Mr. Chair, could, maybe you could just tell us what we're planning on trying to accomplish when we reconvene. Are we going to, is there more public testimony? Are we going to get to, what are we?
Thank you, Senator. The situation is very fluid here, and so it'd be my intention to go into recess, visit with some various members. If we feel that we've done all no more testimony, that if we feel if we've done everything we can do today, that we would come back and adjourn. If we feel we can make some headway on some issues on the side-by-sides, we would continue to work until we have nothing else to do. So with that, any other questions from our Senator Laurie?
So just curious, in this break, you mentioned that you might be getting together with some members. I haven't been notified about any of that. Would I be included in those some members that might be engaged in the conversation?
Laurie,
I just.
You haven't been contacted because you're not included.
Okay.
So, okay.
Well,
and members,
point, Mr. Chair,
members,
I will be included.
No, not if you're going to break a quorum. We have to be very, very careful on open meeting laws. There will not be 3 members from each body meeting at all. I'm going to go around and do some visiting. We're not getting together behind the scenes as a conference committee. We will not break open meeting laws, and you're not invited. So with that, we are in recess till 3:30 or the call of the chair.